Hello, and welcome to Hospice Insights, the law and beyond, where we connect you to what matters in the ever-changing world of hospice and palliative care.
Making palliative care a win-win-win. A conversation with Dr. Bethany Snider, Chief Medical Officer, Hospice Health. Bethany, thanks so much for being here. You're so fun. So thank you for making the time for me.
It is a pleasure to be with you and talk about one of my most favorite topics, which is palliative care.
I know. And it's like as I've gotten to know you throughout the years, every time I talk with you, I learn tons of stuff. And then I'm like, but you're a physician. How do you learn all this business stuff, which we'll get to later, but you're a jack of many trades. So, but I guess just to level set as, to the extent our listeners don't know who you are, tell me a little bit sort of about your professional background and how you got to your current role.
Well, it's an interesting story, Meg. So I am one of those that was a patient first, and I had an experience with the healthcare system when I was a teenager that kind of left a sour taste for me. And when I reflect back now, it really was around communication, or rather lack of communication, by a physician of mine that had a significant impact on my life and decisions I was going to have to make. So that kind of spurred me into medicine. I love taking care of patients. I also love my home. So I've lived in Kentucky my whole life, and I knew I would always serve my neighbors and my family. That's really important to me. So went to medical school at the University of Kentucky. When I started, I thought I was going to be a pediatric neurologist because of my background as a patient. Yeah, thank goodness that didn't work out.
It all makes sense in reverse, right? You're like, oh yeah.
I don't know what I was thinking.
Dodge a bullet on that.
Right. So kind of went through schooling. I signed up to do internal medicine first. So I was like, that's the last thing I'm going to do. And I loved it. It changed my whole trajectory for my career. I loved seeing all the different specialties. And I got a lot of exposure in ICU during my internal medicine training. And I was blessed by an attending that said, you really need to go check out palliative care. Because when I was in the medical ICU or the cardiac ICU, I would always trade procedures with my colleagues to go have difficult conversations. And nobody else was doing that. And at the time, the doc was like, have you heard of this palliative care? Which I didn't know anything of it. I'd had some family experiences with hospice, but didn't even realize it was a medical specialty.
Yeah.
So I was blessed to rotate with Hospice of the Bluegrass as an elective during my residency, and then changed my whole career path and went straight into fellowship after finishing internal medicine. I got to hospice through that journey. As you all know, Hospice of the Bluegrass is an extraordinary organization that had a unique model where physicians spend a lot of time in the hospice environment and we're full-time physicians. And to walk into somebody's home, such a humbling experience when they're going through something as difficult as a terminal condition. And you learn so much about people. You also see why it's really challenging to adhere to the healthcare system that we're giving them today. And I knew in that moment that these were my people and this is the type of care that I was passionate about. So I haven't looked back, and I've been with Hospice Health ever since I left fellowship. And it's truly been a rewarding journey. But as you alluded to in the intro, I learned a lot about things that I enjoy and how my mind works that's outside of medicine. So I just am very grateful that I get to stretch those things and think about building solutions at a system level, not just patient to patient, which is still very valuable too.
But I do think that grounding in being a caregiver and that compassionate physician, and I just think there's nothing better than a physician leader who still, has a foot in, I, I, I didn't just go to medical school so that I could advance from a leadership standpoint. I did it because I really loved it, but I also have all these other gifts, and finding a way to do that. Because I know as we're recording, you're sitting in a hospital now. Like, doing clinical stuff. So, yeah, that's such a wonderful story. And, yeah, what is it about people? Because obviously I feel like hospice people are my people too. And like people, I always say they lean in to what everyone like runs away from.
Mhm.
And like there's something about people that can do that. And I just had a hospice experience with my mom, and being on the patient side of that, family side of that, I totally get what you're saying of you're walking into a lot in that moment of
Mhm.
crisis, and you know, people are like making a lot of decisions. And there's just very tense experience. And to see the skill of this hospice admission nurse, Angie, it was like, I don't know how she did it, but it was like magic what she was able to do. And so so it it really takes, people with those gifts. So it's wonderful you found your path to hospice and
Mhm.
palliative care, because it's so needed, and not everyone, as you said, likes to do that work. And so I wanted to focus a lot of our conversation on palliative care because I think it's like this nut we keep trying to crack, as an industry. You know, Probably 15 plus years ago, people were starting palliative care programs, and the struggle has always been there's no payment models. So, then you're just billing Part B, and that really falls short of, what I think people want to do, and really making a difference for the patient in sort of all the different ways we probably can do. So, I know you all have been able to build a palliative care model despite the payer constraints or payment constraints we have into something pretty cool that is very impactful to patients. So tell me how you sort of crack that nut, because it's beyond just, oh, we bill Part B for consults, and we, leverage NPs because they're cheaper. So that's like the model. And then, because we all know that's not really sustainable. So
Mhm.
tell me what you did.
Yeah, so I think a lot of wisdom was paid for me when I took on the role of chief medical officer. And at the time, hospice knew they needed to get back into community-based palliative care, and they were trying to be strategic about how we did that. And so initially, our focus was actually on payer arrangements. So, how can we learn, better understand payers, Medicare Advantage plans, so that we can tell our story better? We can articulate our value to other partners with aligned incentives, and then work to grow those models. So in 2015 to 2016, we were talking to every payer that would meet with us. Most of them had no idea what palliative care was. Some had some experience with some of those models you alluded to, but
Mhm.
they weren't actually delivering on outcomes they were looking for.
Mm.
So through that work, and I always chuckle because I was sent to these boardrooms in these major national payers by myself. Like we had a transition of my like co-leader, and I'm going to these places, and frankly I had severe imposter syndrome. I was like, I don't know what I'm doing. I don't know why I'm here. But I knew what patients need, and I'd seen that
Yeah.
firsthand. And so I could tell that story. And I think that the most critical lesson I learned early on in our PM arrangements or per member per month arrangements was I had to find the people that had aligned incentives. And what I realized with just payer arrangements in our market at that time, they didn't really have an aligned incentive with what we were trying to figure out. But
Yeah.
we had some big health systems that were starting to take on risk. So they were actually sharing some risk with Medicare Advantage plans and were struggling to control costs for their seriously ill population. And so this is a strong partner of ours on the hospice side. And we had some conversations. And so we brought them to the table with one of these large national plans. And they were willing to pay what we needed to build a palliative care model that's interdisciplinary, that is a comprehensive wraparound service with 24/7 access, all of the things that really speak to high quality palliative care, so that we could try to help them change the trajectory for that population. It's the program I'm most proud of because it still stands today. So we still are in partnership with that MA plan and that health system to manage these high risk patients. And we're trying to figure out how do we continue to expand that to other plans and other programs within their own health system. And so, right, there were some really good lessons there. At the same time, we were talking to other plans or health systems, and I'll never forget a CEO of a large health system said, "Well, I don't want you to keep them out of the hospital. When they come to the hospitals, when I make money."
Yeah.
And so, that really caught me off guard. I was like, "Well, hold on. Patients don't want to be in the hospital. We
Yeah.
know that. The data's there. But, right, business lesson for the doctor over here that it wasn't an aligned incentive for them." Now, interestingly, today, we now have a partnership with them because the incentives have changed.
Yeah.
And so I think it just shows it really behooved me, but also us as leaders in this space to learn about our partners, to understand how they're being graded, kind of where are their financial pain points, so that we can figure out where does advanced illness or serious illness care kind of meet them to help solve for those solutions, recognizing that we are the experts in community-based care, right? That really is our expertise. So I'm grateful that we've had a couple payer arrangements. We've had some health system arrangements. Now we have another at-risk provider arrangements that are still interdisciplinary palliative care. And that's one thing we've really stuck to. Our mission is to provide care that enhances the quality of life for all impacted by serious illness. And so I will not allow us to compromise our values for what that actually is. And so sometimes we'll be in discussions with partners and we'll say, there's not alignment in mission. So this isn't the right partnership. Or we had a payer arrangement where we thought there was alignment. And then over time, it didn't pan out. And we weren't trying to solve the same problem. We didn't want to support patients in the same way. So we said, it's okay, but we're not the solution for you. And so that's really hard, I think, especially for legacy hospice organizations, because we want to be everything to everybody.
Yes. Totally.
And that's just, I've kind of taught our team that we can't be everything to everybody because then we don't do anything well. And I really do believe in that. I think we had to figure out what was our specialty and we had to lean into it.
Well,
So
you need, yeah. Well, you need to have a checklist of these are our non-negotiables, because or else you start floating in the wind, right? I'll try to do this, then I'll try to do that. And then you're not really doing anything well and you can't really get anything off the ground. But I think that's a real struggle for folks right now, because I think there's the sense of urgency, I need to get into this space. And so it's much more of I need to fill their hole. I need to fill their hole. And they all sort of want different things. And it's you sort of picked this is what I want to sell, so to speak, or this is the solution. And does it match is there a match, so to speak, with who that partner is? Because I just, there's a lot of wisdom, but like you said, when people feel urgency, everyone else is doing it, I need to do it, I need to get one, in the bag, I need to figure this out. And then you don't have well, is this really what aligned with what we were trying to do? I think is so helpful. I mean, right, in life too. There are a zillion choices you could make every single day. And what matters to you? What is your life philosophy? Right. And because if you don't have that, I think it can be a bit overwhelming. And I think especially at a leadership level, your staff ends up getting pulled in lots of different directions. And then if there's not sort of a unified vision and this is what we're doing and why we're doing it, then hard to get people, behind. Not that we don't all pursue things and then you're like, oh, I'm cutting the cord on that. That didn't work out. Go early, like cut out early. I mean, we've all tried things that don't work, and but I really like that. And my guess is that first conversation, the first partnership was scary, and there's a learning curve and all of that stuff. But I love that it started with stories of patients. I mean, it sounds like, right? I mean, most people that went into healthcare went in there for the human to human part and to improve life. And sometimes you just sometimes get drawn into other things. And so it sounds like that was key to you establishing rapport and credibility because you obviously had never done this before. So where do you start? You start with stories, right?
Absolutely. And I think the beauty of that is it tells the story of what palliative care is. So when you think about these business leaders, frankly, that we're talking to as we try to get palliative care arrangements, most of them have a pretty small understanding of palliative care. But when you can articulate for them the patient that's been to the hospital 6 times in the last 6 months for their breathing difficulty, and palliative care comes in and wraps them with 24/7 access in this crisis plan that then has cut those emergency visits down to 0 or 1 in the following 6 months. And then the social worker finds them transportation or helps ensure that their electric stays on because there was an issue, like
Yeah.
that story is way more impactful than me saying, well, our model is this. And if you pay us, like it doesn't mean anything because most people don't, I think, understand what true palliative care can do. So those patient spotlights have been critical when we were getting off the ground, but also continually as we expand programs or add geographies to tell the story. And I've seen so many system leaders or executives read them or hear those stories and, they say, wow, like this is actually how healthcare can and should be
Yeah.
if we invest in the right things. And so I think always letting the patient's voice kind of guide us on what they need is the best strategy.
Yeah. Well, and I think, and this goes into when you're, in a per member per month um, arrangement, the who is providing services matters. And I think, you know, nothing against physicians and nurse practitioners. They obviously are an important role, but there's lots of other people that can make a huge difference. Which is like if that's a tech in service or whoever they're calling on their crisis plan, it's probably an RN or whatever. It's like I feel, and that's the challenge with the Part B model is it really just is about nurse practitioners and physicians largely, and yes, there's a role for them. And though to meet the outcomes you're talking about, you're not going to be able to do that if your model is just a physician and NP, because it is that, supportive care management, case management, whatever you want to call it, is helping support people so they don't feel like the only help I can get is call an ambulance and go to the ER because I'm feeling very panicked. Because I think we've all been in those situations when it's you personally going through that or your loved one, like having a number to call. Like, I wrote all the phone numbers of the hospice by all the phones. Um, like when we got that phone number, because even doing this for 25 years, I could see that my instinct might be to call 911 if something,
Absolutely.
and so I just think it's like the small stuff that not small in the sense to minimize it, but it's not like the fancy technology. I mean, I think I want to ask you about how you guys leverage technology in this, because I do think it has a role, but I just think it's there's just a lot that can be done outside of, um, you know, just physicians and Ps. But so how do you guys use technology to deliver this? I mean, are you doing telehealth stuff? Are you doing just phone call? I mean, you cover a lot of Kentucky, which a lot of that's rural. And so I don't know if broadband is a challenge. And so tell me a little bit about how you leverage technology in your model.
I'm so glad you asked, Meg, because I think this is the solution for Part B practices. And I want to encourage my colleagues across the country, but also challenge them. And I think our traditional thinking. So we operate a very large community-based practice that is Part B primarily. And it's taken us 3.5 years to get it to a healthy place. I'll talk some about that over the next few minutes, if that's okay, because I think it can really help people as they try to solve for what you just said. How do we serve this population that's likely distributed across a large geography with very limited revenue streams? One way we have to do that is through leveraging technology. So our leadership set a bold goal 2 years ago that they wanted us to get a third of our visits by telehealth or telemedicine, a third of our visits in the home, and a third of our visits in a facility-based setting. So that could be a clinic, a hospital, whatever, nursing facilities. Because with that model, we knew there was a path to more sustainability financially. We started at 0 telemedicine, 100% home, frankly, maybe 2% nursing facility. And our CEO wanted us to get to patients within 7 days. So at the same time, we were taking around 28 to 32 days to admit a patient, which, as you can imagine, with these seriously ill people, that's way too long. Because we were trying to go to the home for everybody and we had limited resources that we could invest in. So you can imagine our leadership team that oversees our palliative program was like, okay, well, this is a nice challenge. And I'll never forget the medical director that reports to me. He was like, this ain't going to work. Like, I remember that like it was yesterday. But we went after it anyway. And so today, right now, 70% of our admissions occur via telemedicine. Because what we found is if we can leverage that to onboard them to the program, we can get to them a lot faster and we can triage their needs. Now so then okay, this person has something acute. We need to follow up quickly, or this person kind of just needs to get in the fold. Let's do some advanced care planning. That's not as urgent. But it helps us to build a relationship swiftly. And I challenge my colleagues all the time when we're at national meetings talking about telemedicine. Oh, well, our patients can't do it, or, oh, it's connectivity. For a very small percentage, that is true. And we have to augment our model. But the vast majority of people in this day and age have figured it out because we all were forced to during the pandemic. It's like one bright spot of the pandemic is we all had to adopt technology very quickly in healthcare. And so we don't have that issue. Our script for our patients is we admit you through telemedicine. That's our quickest way to get you into our program, right? That is a billable service. So we have a provider actually do that initial visit. But to your comment, we've got social workers on our team. We've got nurses on our team. Then we have nurse practitioners and physicians. So we truly have the interdisciplinary team. And we leverage spiritual support kind of based on need identified. But we had to change how we delivered care. And when you come from hospice, these high touch models where everybody wants to be in the home and that's the only way you can care for people, it's never going to work. Like we saw for probably 2 years before we took on this telemedicine initiative, we were trying to move the needle on productivity and visits per day. And we were banging our heads against the wall. Like we couldn't figure it out. We couldn't solve the problem, even with scheduling and all the sophistication we tried to build. But telemedicine really shifted that for us, so I think it was actually 41% of all visits we made last month were via telemedicine. And then it was the rest were home or facility. So we got to our pie of a third, but we're actually heavier on the telemedicine side. So that
was it hard to get your clinicians? Because I think in hospice, the clinicians like the touch too, and so how did you, any resistance there? And then if so, like, do you have the poster child who's like, I hated this, didn't think I could make a difference. I didn't feel like the same passion for what I'm doing. And then they start using it and then feel, that goes out the window. Like,
Yeah, I think we employed two strategies in change management to help get this across the finish line for our team. And just to put in perspective, it's around 14 nurse practitioners now and 5 physicians that generally work on this team in addition to our social work and nursing resources. We found the early adopters. So I had a nurse practitioner. She's worked in
okay.
our organization for years. She had done hospice for probably 6, 7 years and then wanted something different, had relocated to a more rural area that we serve, so transitioned to palliative care. Well, what she found is her community desperately needed palliative care, but the windshield time was killing her. So she was all about trying out telemedicine and she adopted swiftly to where now she does 2 telemedicine days in a week and the other 3 are in the home or in a facility.
Yeah.
But we didn't even have to ask her. She went after it, yes, because she couldn't get to her patients otherwise, right? Like
Yeah.
she had this caseload that she was managing, it was growing. And she figured out, well, if I do telemedicine with these kind of routine follow ups, that allows me to continue to touch them and interact, but then I can get to these other patients or I can get to these admissions quicker. So she was our mouthpiece, frankly, right? She had this great experience. She saw how it helped her manage her patients better and to manage the volume that she was experiencing because she didn't want us to have to put a limit on the patients we could serve in her market because she just saw the need was so great. It's extremely rural. It's at least an hour south of Louisville Metro. So these people really only have a critical access hospital close, but like they have no healthcare access. They needed support desperately. So we leveraged her stories during team meetings. But then the other thing we did is we early on surveyed families and we asked them about the telemedicine experience. Like rate it for us for your needs met. Did the technology get in the way? And families and patients overwhelmingly reported as positive experience. I think it was like 4.7 out of 5 is how they rated it.
Oh.
So that also reinforced for me as a leader, this is the right thing. Like they've adjusted to this interaction. Now we have to adjust.
Yeah.
And so we continued to find those champions early and had them tell the story because frankly, nobody wants to hear it from me, right? Like I'm just the doc and
Yeah.
office, right? And then what we saw over time is more assimilated to it. And they started to adjust their schedule to add that day in or 2 days. And then eventually, after we got enough traction, then we changed our model to say, okay, everyone has to have 2 days a week that either are telemedicine days or in a clinic or facility. So we just kind of said, like, this is now our new model
Yeah.
so that we can be sustainable. And everybody's in that model now and they're doing fine. Because what that allows us then is you still have home days where you're making half as many visits as you make on a telemedicine or a clinic facility day. And that balance has pushed our program to a sustainable path, which I'll talk about in a second. But I did want to address the nurse social worker piece.
Yeah.
So I, like you, agree 100% we have to be interdisciplinary. And if anybody listens to this podcast and is trying to figure this out, they need to go spend time and energy learning about principal care management, which is a care management code that we can use to bill for clinician time under the direction of a provider. So we saw that code come on the scene, I think it was 2021, and we started to figure it out of the gate because we already had these resources on our team that we were investing in because it was the right thing, but we wanted to try to get credit for the work they were doing. It's an easy process. You have to change some of your workflows because it's plan of care driven, which is not traditionally in a palliative care space, something we worry too much about.
No.
But in 2024, we generated $360,000 in revenue just from work RN and social workers were doing. But if you think about that team, right, we paid for our social work team just by capturing what they're doing and then billing for it in that way. And so that to me is, you're right, Part B by itself isn't profitable. But when you pull all the levers of some PMPM, a large volume of Part B, but you have to maximize these additional codes and then evaluate the contribution to your hospice, there is a win. And we saw that this year, where when we count all of those things together, our palliative care program covered its expense. And for
Wow.
us, that was a game changer, right?
Yeah. That is, that is amazing. And I mean, it didn't happen overnight, but so I'm trying to think back. When was it? You said you went to your first meeting. Was it
2016.
Okay, I was going to say 2015. Okay.
Yeah.
So, and I'm sure
Yeah,
many bumps along the way and retooling and all this
absolutely.
stuff, but like you're doing it. And yeah, it's like not afraid to try, but, then being grounded by what are our values? What are we trying to accomplish? And then, staying up to speed on like principal care management codes, like other things that are going on, because there has been, you know, some changes in Part B billing codes, that it's not just evaluation management. I mean, there's other opportunities. And so that sort of brings me to the whole, and this, in addition to telling patient stories, and maybe they're the illustration of it, but is really about the data, the impact, and the impact being measured. And I think when we've worked on negotiating payer agreements, really trying to push on this data piece, and
For
not
sure.
just a one-way street, it's got to be two-way street.
For
Because
sure.
if you have blinders on and you don't really get to see the bigger picture, and only your payer partner is seeing that, like that isn't very helpful. So tell me about the data piece. Like, what do you measure, and how do you, work with the payer to get you that data? And like, what data do you think is important, and how did you begin that process? Because it's a real heavy lift to show value when you've never done it before. So how do I show value? Because it's like the chicken and the egg thing. So
Yeah. Data is king. And I think my guidance to people is be narrow in scope initially and validate that your data is accurate and it's telling the story it needs to tell. So I'm the type of person, and my team knows this. I always say, well, what's the data show me? Because clinicians, especially, we love to operate by the exception, not by the rule. And so I'm always challenging, well, show me the data. Go get the data. So I love data. So I'll say that as kind of my
yeah.
disclaimer. However, what I've learned in this process is we had to be really strategic around the data elements that we captured consistently and measured, and then helped us to augment our models or adjust our practices over time. So there are 1,000 things you could measure, but I would try to be narrow. I think on the clinical side, going off the National Quality Foundation kind of guidelines and what they recommend is a great place to start. But on the business side, it's really important to think about what's the value to your organization, right? What are you trying to show value to your board or your stakeholders?
Mhm.
And to your comment that we have to hold our partners accountable to the data that we need. Payers especially, they want access to everything. Like they wanted us to send data hourly, it felt like. Like,
Yeah.
can you do this report this day and
Yeah.
this report that day? And I mean, that can be really overwhelming to organizations our size. So we did push on them. We also, with all of these agreements, asked for transparency around claims data, particularly Part A and Part B spend, because that's what we can impact. So I do think it's important for organizations like ours doing palliative care to recognize Part D is not where we are. So most medications that are extremely expensive, we have very little influence think of your cancer drugs like immunotherapy or pulmonary hypertension meds. We actually had a story with one of those early payer programs where we were serving a couple hundred patients and they were doing a claims data review, and it kind of showed some data we weren't impressed with, and neither was the health system. Like we had seen through, ER avoidance, like behaviors were changing. So why does the financials look this way? Well, when we dug in, there were 7 patients out of the 200 that had medications that were astronomical, and there was no way to augment those medicines, right? Well, then that taught us a lesson for all of us, all 3 of us, that we had to actually cut the data differently and in a meaningful way that truly evaluated, is palliative care meeting the outcomes that we've agreed upon or not? So that was one thing we learned early on. Like, total cost of care is important, but we shouldn't take on responsibility for total cost of care if we can't influence total cost of care.
Totally. Amen to that, because I just feel like when you talk, everyone gets so excited about, incentives and it's like, but what can you really impact? Because there could be awesome outcomes, but do you think you can have a measurable impact on that? Because I just think people get real excited, and it's like, you don't want to be the downer, the Debbie Downer, but like, yeah, it's like, because, right, at any conference you go to, it's like, you got to find out, what they need. And then you got to provide the solution for what they need. And so they want to reduce overall costs, like you say, but like, okay. And they might say something, I don't have a great example off the top of my head, but like, you're not going to be able to influence that, right? Or so I think it sounds simple, but I think so wise, because that your example with the drug is like huge.
And here's another piece of that. You're absolutely right. This again goes back to legacy hospice. Oh, we want to help them. We want to be a great partner. Yes, and we've got to be able to deliver, which is what makes us a great partner. And and so I chuckle. The other thing people need to really be thoughtful around is the patient population they're targeting. So when we talk to our payers or our at-risk providers that we're working with, I am very intentional that this population we're serving with this high needs program, where we're getting this PMPM that's sustainable, that's not for anybody with serious illness that's palliative care eligible. That's for people who have high Part A spend. They are utilizers of the system, because you can have advanced heart failure that on paper looks terrible, but if you're not utilizing the system in a way that we're trying to augment, then again, palliative care can't actually deliver on the outcomes desired. Now, in a community-based program, can we support them and add value and improve their quality of life? 100%. But when we're thinking about the business of palliative care with these providers and payers, that's not actually their alignment, right?
Yeah.
They care about their members and their patients, but they're looking at the value in a different way. So we always push them when we look at, the analytics that are going to drive patient referrals, to say, yes, they need to have a qualifying diagnosis, and they have to have a threshold of acute care utilization for us to impact. Otherwise, we're not going to win, right? We don't know what winning looks like.
Yeah.
Because they're trying to get us to curb expense. Well, there has to be expense to curb. Right?
Yeah, exactly. Oh, that's so well said.
So I think that's one piece. The other thing I would say, especially if you're a legacy hospice organization like we are, we didn't do this initially. We should have. You've got to build the data out of the gate to show the contribution to your hospice. Because there's this tension culturally between hospice and palliative, even within organizations under the same house. And so some of the value we can show to our colleagues in hospice is that they get these patients sooner. They have double or triple the length of stay in hospice, which is better for everybody, not just the patient and family, but also financially for the hospice, just because they're getting better lengths of stay. The churn's not as significant on their clinicians. So that's the other piece we learned along the way. External data and outcomes critically important to continue these type of arrangements. but internal buy-in is just as important as you're expanding your services. And so I think that's the other piece that we learned the hard way, but now have built, dashboards to guide us across all of those stakeholders so that we can easily say, these are the patients that were impacted. This is their value and length of stay added by coming through palliative care. This is actually the financial contribution that then translates to, because our board had really challenged us. They wanted to see what is the value of this investment. And I can say, thankfully, in 2025, they are 100% behind this investment and the programs that we've built in palliative care because they've seen that value proposition and how it's grown over time.
Doesn't happen overnight, but it happens, right? And that's just really, really exciting. And I wanted to have you on the podcast because I think your passion about what you do and how you did it is contagious. But I also think you're just really smart and thoughtful, and patients are at the center of what you're doing. And it's not, right? It's always said, no money, no mission kind of thing, right? Yeah, there is a business of healthcare, but it doesn't mean that we don't care about, quality outcomes and all the things we have always, what got us into this work to begin with is having an positive impact on patients' lives and reducing suffering, right? So
absolutely,
we're doing all of that stuff. And it takes smart minds like yours to, connect, the patient stories and that passion, because that's what gets you up, in the morning about to serve is I remember some of these stories uh, with those floods in North Carolina. Was it like fall or whatever? But these nurses going out, crossing rushing rivers and setting up these makeshift clinics, caring for people in these rural areas that no one could get to. And you're and stories of clinicians in West Virginia, rural areas, doing amazing things for people. And it is that right. It is amazing. And it's so, we're so lucky to have people in the world that do such important work, but you need to have all of this businessy stuff too, right? And so to be successful, you need people like you that are thinking big picture. You need the people that are at the bedside, it takes all. But but all of this stuff is really hard. And I think, we're, as an industry, we're really relying on Medicare. We're trying to diversify, but Medicare is going to always go bankrupt in the next couple of years. Do we have Social Security? All of this stuff. It can be, and regulatory enforcement, dealing with all the time, and so I'm sure you have your days that you're down. But how do you stay motivated and inspired? Is it doing something totally different? I love making stuff. So I paint and I make jewelry and I garden and do all this other stuff that has nothing to do with what I do in my day job. What keeps you inspired and enthusiastic?
Yeah, I think a couple things. One, my team knows very well that I think boundaries are the utmost importance. And I didn't have great boundaries a long time ago and knew what that felt like. And I'm blessed that I have this keen awareness of when I'm falling over the cliff. And so I had my first child and I realized that had to be different because at the end of the day, this organization will go on without me and they'll replace me and it'll continue, right? The work will continue, but my family gets one Bethany, right? One version of myself. And I believe this work is a calling that you've alluded to. People are drawn to this work for a reason. You don't just happen here. Just like to me, motherhood is a calling. And so I have to value both. And so I'm very intentional. Like, yes, I'll work hard and I'll do my part and I'll come to the hospital. But when it's time to be at home, I'm at home. And I love doing different things. So I studied music in college.
Oh, wow. Cool.
And music has been my life as long as I can remember it. So I am the pianist for our church.
Oh, that's
I
amazing.
lead the children's choir. So
Oh,
that's the fun I get to do tonight when I get out of the hospital is go work with 30 crazy children and turn it into beautiful art through music. And those things remind me of why I do this work. Um, Palliative and hospice changed my life. Medicine is not easy, and it was extremely difficult in training. And I was a different human and was bitter. And then I found this beautiful place where we valued people and we realized that it's an art and it's not a science. And we got to understand like what mattered to them and what their values were and the things that they loved. Like we got to know them as people, not just numbers or a diagnosis. Um, and like I couldn't be more grateful today.
oh,
And so I think that that's really helped shape my perspective. I mean, I think you can hear in it like faith is a guiding place for me
yeah.
and it keeps me grounded and it reminds me of the main thing. And I think in this work, like all people, like this is the reason I get up and do this work is all people should have access to this. And I'm going to fight like hell
Yeah.
to try to get that for them. And I think about that in Kentucky, but beyond, I don't care if you live in Pikeville or Paducah or somewhere in between. You should have access to high quality palliative care, even if you're not interested in hospice. Like that should be a thing that you are entitled to because all of us deserve to have a good quality of life when we're dealing with serious illness and our patients' families deserve support. And so it makes it easy to do the work when that's what you're
Yeah.
fighting for.
Totally. Totally. So, so amazing how it parallels because I too found going to law school like almost was very hard, but also sort of lost myself. And then through finding my way to hospice and then been doing this for 25 years, like I don't think I could have been successful, nor would I still be a lawyer if I didn't find the, hospice people because it's like the uniqueness that I bring to what I do like resonates with hospice people. Like probably, I wouldn't resonate with like real estate people or, whatever. Like my vibe is not, but it's like, yeah, like life really makes sense in reverse about how I found my way here. And I think it is where I've been supposed to be and just really yeah, I've gotten to meet amazing people and be part of, in my small way, like helping people do really important things in the world that really matter. Um, and then when, I started hospice volunteering and that was something I was scared to do because it just like, it's going to be uncomfortable. And then you just realize it's like humans caring for humans. And it just like, yeah, it's prepared me really well to like be a better human in the world. Like it is
Absolutely.
so hospice has completely changed my life in so many ways for the better and how I want to live my life and everything. Um, so thank you so much for sharing your story and just like all of your wisdom and just pizzazz for life. And so this all got started because I think several years ago, I was like, you need to be on my podcast. And then, life gets in the way or whatever. And then you were in the New York Times. I opened up like my
Oh, yeah, that
well
was
thing and
crazy.
I was like, oh my God, I know her. Anytime I see like someone in the New York Times that I know them. I was like, oh my God, that's so cool. And so it rehashed our let's do a podcast. So
We made
so
it. We got
we
there.
made it. We got it done and you're just awesome. So
Well,
thank you.
I
Thank
got you.
you. for all of your time and just what you do. You're really inspiring. And so it's like there must be like amazing women clinicians in like West Virginia, Kentucky, North Carolina. Like I've read very inspiring stories of women in like rural areas that are like just the ends of the earth they would go for you. So
that's awesome.
Yeah. So thank you for all you do. And thanks so much for your time today. This has just been a wonderful conversation.
My pleasure. We can do it again soon,
Yeah.
Well, that's it for today's episode of Hospice Insights, The Law and Beyond. Thank you for joining the conversation. To subscribe to our podcast, visit our website at hushblackwell.com or sign up wherever you get your podcasts. Until next time, may the wind be at your back.